This lecture will be about restless legs. I'm just hoping I'm not gonna be, way above the time, but I'll try. I have no financial disclosures. So the objectives for today, we will review the current literature regarding the pathogenesis, pathophysiology of what we call primary and secondary RLS. There's not really a clear-cut distinction in the general literature, but there's a lot of talk in regards with what's primary, what's secondary. Secondary is basically related to diseases associated or who could trigger restless legs. We will review the clinical features, including any comorbid condition that may impact sleep, both in adult and pediatric populations. So you will see kind of the lecture is a little bit divided into. And then we will review differential diagnosis, how to make diagnostic distinctions in adults and pediatric patients. We will review the current therapeutic guidelines. This is basically half of the presentation because that's the new kid in town, as already mentioned. And then we'll speak a little bit about the impact on quality of life. In terms of resources, I highly encourage you to look on the website of the RLS Foundation. That's easy to just Google. Lots of cool stuff there. There's also some links to really nice video presentations from Dr. Winkelman, who is a big name in RLS world. So what is restless legs? It is a sensory motor disorder with significant negative impact on sleep onset or sleep maintenance, quality of life, general health, is significantly under-recognized, under-diagnosed, under-treated. Just to quote Dr. Winkelman, he's like, okay, they don't have it because you didn't ask. So the prevalence of systemic and nocturnal hypertension, cardiovascular disorder, white matter changes, even AFib in patients with RLS seems to be higher, especially if they have PLMS. The PLMS, I know you've touched a little bit about, so they are a polysomnographic finding, and we will go in depth also on today's lecture. And this happens because there are some changes in the sympathetic nervous system, which triggers more cardiovascular disease. And RLS seems also to be related to a higher prevalence of mood, anxiety disorder, increased suicidal risk in depressed patients, increased rates for ADHD, increased risk of insulin resistance, type 2 diabetes, and also impairment of sleep-dependent memory consolidation, which is important. And as already mentioned, RLS is classified both as a sleep disorder and as a movement disorder. So we share this a lot with neurologists. And it's categorized by an unpleasant or uncomfortable sensation in the legs with an irresistible urge to move them to fix that sensation. And then what this happens, then starts again and all over, kind of the process continues up until the person is able to fall asleep. It happens late in the afternoon or anyway in the evening hours, usually when the patients lay in bed, stretch their legs in bed. And it's worse in the night. May happen also if somebody is inactive and sitting for extended periods. This is also a triggering factor. Moving the legs typically relieves the discomfort. This is very important when you ask in clinic the patients. Because there's a lot with RLS being a clinical diagnosis, it's basically a lot of subjectivity involved with that. So it's very important how you ask the questions because also many people have neuropathy or osteoarthritis or other things happening. It can lead to difficulty to concentrate, impair memory, as already mentioned, and fail to accomplish daily tasks. So what do we know about the epidemiology of RLS in the adult population? It is believed that 5 to 10% of the US population may be affected, both men and women, but women are actually they have a 2 times higher chance to have RLS. And this would most likely be related to the fact that women are menstruating, so there's a higher chance they have iron deficiency. More than 80% of people with RLS also have these periodically movements of sleep that we see on the PSGs, but not all of them. And 2.5% of adults have clinically significant RLS, so symptoms for at least 2 nights per week. In the pediatric population, less data because it's less studied, and I guess we don't really ask so frequently for a well-child visit, but in the US alone, we believe that it affects about 1.5 million of children and adolescents. About a third of these patients report the onset of symptoms before age 20, and 1 in 10 report that the syndrome appeared during the first decade of life. And it's good to mention here that the early onset of disease, like before age 45, it's more familial and is associated with a slower progression, unlike later onset of the disease that could be more severe. What are some common signs and symptoms? And again, it has to do a lot with the patient's perception, and different people describe different things in different ways in their own words: aching, throbbing, pulling, itching, crawling, creeping sensation. It could affect both sides, but it could also affect just one side. It could affect upper limbs as well. The severity is different, uncomfortable, irritating, painful, but the more pain it is, the less likely it's RLS. So it's a lot of, again, being judging really good the clinical situation. Moving the legs relieves the discomfort, and the symptoms are worse at night, but most patients report a distinct symptom-free period towards the morning, early morning, and they usually have a little bit more refreshing sleep at that time. So what causes primary or idiopathic RLS? Long story short, we don't really know what's the cause in most of the cases, but there are 3 important causes that are evidence-based. Genetic traits, specifically BTBD9 and MEIS1 genes, low levels of iron in the brain, so brain iron deficiency, and a dysfunction in the basal ganglia, so that area of the brain that controls movements, and the use of the brain chemical dopamine, so dopaminergic dysfunction. Basically, you will have a hyperdopaminergic presynaptic state and a hypodopaminergic postsynaptic state. And we will go over this a little bit later when we talk about treatment. Multiple other mechanisms, lots of studies out there, but the genetic traits, the low levels of iron in the brain, and the dopaminergic dysfunctions, these 3, I mean, we know for sure most of the patients do have them. What do we know about iron and RLS? So iron is very important for the biosynthesis of dopamine, and it's specifically necessary for tyrosine hydroxylation, which is a rate-limiting step for dopamine production. So I guess, you know, we can't really talk separately about iron and dopamine. They kind of come together, and then we have those genetic traits. Iron, most importantly, is absorbed under a circadian mechanism and these complex genetic determinants, and most importantly, also related to the iron availability in the body. So extrapolating from animal data, it could be said for humans that systemic iron deficiency will reduce brain iron in select regions in some individuals. And some individuals with normal serum iron levels will still have low iron in the brain, because we're talking about like certain regions, the ones that are involved in movement and sensory impairment. And the serum measures of peripheral iron, which is what we do in our clinics, are unlikely to be related to the actual level of the iron in the brain. And they are poorly related to RLS expression. But since we cannot really check the brain iron, the option we have is to check this one. And I feel this is one of the reasons why the current guidelines have significantly increased the cutoff for iron supplementation in both adult and pediatric patients. So now we'll talk about a ferritin level of at least 100 and the transferrin saturation of 20% and above. And that's different compared to previous guidelines. So some imaging studies for primary RLS have shown low brain iron content, specifically in the substantia nigra, but also in the thalamus. Dysfunction of the dopaminergic pathways was found in the nigrostriatal and mesolimbic pathways, and also white matter changes were found on MRI studies. And to summarize, we are dealing with the reduction of brain iron content that leads to a dysfunction of mesolimbic and nigrostriatal dopaminergic pathways that leads to a dysregulation of limbic and sensory motor networks, hence the restless leg sensations. And this is just an example of what tracts are affected by functional MRI studies: corticospinal tract, anterior thalamic radiation, cingulum, inferior front occipital fasciculus, and they are still looking into this, so more data may come. Secondary restless legs is associated with multiple comorbidities. This slide is busy, and I'm sorry about that, but it's quite important because you will find here things that many people are using, and we see them in their charts every single day. And I just put all of it together because whatever comorbidities are associated with RLS are also the factors that are exacerbating the RLS symptoms. So any type of iron deficiency, including nutritional iron deficiency, patients who are post-bariatric surgery, and any type of GI disease that leads to low iron absorption, or patients who are donors, like blood products donors. And keep in mind that we're not talking about anemia. We're talking about reduced iron stores that may not have led to the point of anemia, low hemoglobin. So to be honest, we don't really check CBC unless it's a pediatric patient and, you know, we don't want to stick them 10 times. So we may just throw the CBC with the ferritin, iron, TIBC. But checking CBC, it's not in the restless legs guidelines per American Academy of Sleep Medicine. So what is the second most important disease? It's actually renal failure. About 1/3 of these patients have restless legs. And third most important category is drug-induced. And there's multiple medications that are implicated, and they're implicated specifically because they affect some part of the dopaminergic pathway. So antiemetics, antipsychotic drugs, all TCAs, SSRIs, SNRIs. TCAs are more implicated, more powerful in inducing RLS than SSRIs and SNRIs. Mirtazapine is actually the worst. Bupropion is neutral. Sage Jorsworth, antihistamines, first generation, more than second generation, any PM formulation with diphenhydramine, and we have many patients who are taking lots of these, specifically anti-allergy medications. And then even H2 blockers for GERD could trigger this. And PPIs actually worse than H2 blockers. So if needed, you may consider switching the patient at least to famotidine if they absolutely need a PPI for heartburn, acid reflux. And obviously the decongestants and even melatonin can worsen RLS by a serotoninergic mechanism. So yeah, I do prescribe some melatonin some of my RLS patients, but yeah, if you look at this, you're like, oh my God, because exactly, this is things that we see in every single chart. Alcohol, specifically red wine, can trigger nicotine, caffeine, refined sugar, opioid withdrawal. And, you know, I'm going to cite again Dr. Winkelman. So if opioid withdrawal can give you RLS, there's the reason, one of the reasons why here's opioids that treat RLS. Pregnancy, that's another important one. About 25% of the pregnant lady may have RLS symptoms, specifically in the 3rd trimester. And in most cases, the symptoms usually disappear within 4 weeks after delivery. Peripheral neuropathy. So then again, it's hard sometimes to differentiate in clinic. Is it A or B? What's going on? Or it's just 2 diseases that affect the legs. Inadequate sleep hygiene, sleep deprivation, sleep apnea can also trigger more RLS symptoms. Depression and anxiety. Always assess for depression in RLS patients. There's a really big association between the two. Chronic pain syndromes, fibromyalgia, rheumatoid arthritis, multiple sclerosis, again, frequent reason for people to have RLS, migraine disorder, Parkinson's. In regards to Parkinson's, obviously, it's another dopaminergic disease, but it doesn't mean that you have Parkinson's, you'll have RLS, and it doesn't mean that if you have RLS, you'll develop Parkinson's. And thyroid disease, which I guess it's implicated in anything, right? So,
So do we think that in pregnancy association with RLS is because of the anemia thing? Like, I mean, the low iron thing?
low iron it definitely plays a role, yes. But it's not just that, it's also like endocrine, like hormone changes.
Because why I was curious was when I was pregnant in my third trimester, I had like my hemoglobin was 8, so I was given IV iron.
Mhm.
I had like bad RLS that time. And it lasted, like you mentioned, like it disappeared after delivery only. But
Plus we got IBM.
I got no, but I got the IV iron. So like my other symptoms, like fatigue and like the breathless kind of thing, they improved, but the RLS kind of continued till the end. And when I delivered, that was the time like when it was gone. So I was wondering whether it's just the iron association or something.
It's not just the iron. I feel that's like another, lecture. We can look for that. Come with the presentation. That's actually a really good topic.
First line treatment is going to be the same medication.
Lucky us, except for the iron. Correct. Yes. So that's actually good because many people are on gabapentin, right? And they are now first line. Like all the gabapentinoids are first line treatment. But where is the Bible? It was somewhere on the table. So anyway, ICSD 3TR. Oh, it was Dr. Carter's. Okay. So diagnostic criteria, they're a little bit fluffier than this, but here is like a short version. So criteria A to C, they need to be met. Strong and often overwhelming need or urge to move the legs that is associated with abnormal, unpleasant, uncomfortable sensations. The urge to move the leg starts or gets worse during rest or inactivity. It is at least temporarily and partially or totally relieved by movements, the most important statement. The urge to move the leg starts or is aggravated in the evening or night. The above 4 features are not due to any other medical or behavioral conditions, sometimes hard to determine that. And the symptoms can cause concern, distress, sleep disturbance, or impairment in daytime functioning, daytime fatigue, or sleepiness. But keep in mind that these patients have normal Epworth scale most of the time. That's kind of a bit of differential with the sleep apnea patients. And by sleep disturbance, we mean sleep onset, sleep maintenance, insomnia. So you can have one or both. Moving a little bit, I'm going to jump the guns here a little bit with objective findings, but there's no role of polysomnogram unless you are a kid. Because kids have trouble obviously expressing themselves. So finding PLMS on the PSG, it's helping us to make a diagnosis. When do we usually recommend a PSG to be done is when we believe the patient has other comorbid conditions. Most frequently, that would be sleep apnea. But if a PSG is being done, things that we could found are increased latency to persistent sleep, marked fragmentation of sleep. This patient may have a higher arousal index. We would see a deterioration in both non-REM and REM sleep, but specifically the PLMS are less likely to be found in REM. Why? Because that's when we should be paralyzed. We should not have movement. And we may see association with sleep apnea and periodic limb movements. So since we opened Pandora's box, let's talk about periodic limb movements a little bit. So there are 2 types. The ones that happen during sleep and the ones that happen during wakefulness. They are frequently associated with arousal from sleep. This is something that we report on the PSGs. And the PLM during wakefulness happen during quiet rest and during transition between waking and sleep. PLMS, so the ones during sleep, can appear immediately with the onset of stage N1 and are frequent during stage N2. They decrease in frequency during stage N3 and usually absent during REM sleep. And one other thing that we report is the PLM index. Most importantly for pediatric patients, an index above 5 is maybe clinically significant, and for adult patient, an index above 15. What how do we score these movements? We will have an increase in amplitude in anterior tibialis muscle on EMG of at least 8 microvolts. It lasts 0.5 to 10 seconds. You need a string of minimum for movements, and they happen every 5 to 90 seconds. And this is from the scoring manual. This is actually from the 2.6 version, but the 3.0 version, the newest version, which you guys will have to study, it looks the same. There's no change. So at least microvolts increase in the EMG voltage above the resting EMG. And I will not go into big detail, but an arousal may happen before, during, or after the movement, and it's still scoreable. And here is like a string of PLMS. Any limb movements that happen during a period of 0.5 seconds preceding an apnea, hypomnia, or RERA to 0.5 seconds following the event should not be scored. So we do not score the limb movements associated with obstructive respiratory events because they are, because of that, they are not true PLMS. And that's something for you to follow when you read sleep studies, because I would say in our institution, I'm really proud of our sleep technicians because they're doing really great in scoring these, but it may happen that sometimes are scored and they're not true PLMS. And this is one example. So we have here a series of these periodic limb movements. Moving a little bit forward, now that we saw what are the criteria for adult population for diagnosis, let's talk a little bit about pediatric patients. This data here is not in the ICSD-3, so this is kind of a general consensus, but in kids, we talk about a definite, probable, and possible RLS disorder. But for a definite childhood RLS, the child must meet all 4 essential adult criteria and be able to describe the sensation in their own words. If they're unable to do so, at least 2 of the following must be present: sleep disturbance that is not typical for age, a biological parent or sibling with definite RLS, so positive family history, and or a PSG documented a PLM index of 5 or more per hour. And since kids describe things in their own words, here are some examples: ouchies, ooies, tickled, spiders, creepy crawlies. These I've heard. They want to run, a lot of energy in my legs. I had 2 kids telling me that. Pains, aches, hurts, feels as if they are pulling apart. And because kids know best to express themselves by drawings, here are some examples of kids' drawings that experience RLS, kind of that movement, tossing and turning, some stuff happening here, bleeding. This one, I think it's the most severe one. This is another kid that looks like it's wiggling at night. And this is another one that feels like all this shakiness. You see how, but I thought this was interesting. This is an article, it's available online. You guys can look for it. Probable childhood RLS, if the child has a family history, a biological parent of sibling only, either meet all 4 essential diagnostic criteria or must be observed to have behavioral manifestations of the lower extremity, discomfort when sitting or lying down, accompanied by motor movement of the affected limbs, and possible childhood RLS. The definite of probable definitions are not met, must have PLMD and a family history of definite RLS, biological parent or sibling. So some family history of periodic limb movement disorder, we'll go to that in a second, or family history as well. So pretty hard to make a diagnosis, and I guess the younger the child is, most likely, which is why we end up many times getting a PSG on kids. So what are some clinical characteristics in the pediatric population? Disrupted sleep, it's often seen, and that may happen because of the PLMS, but it's unclear what percentage of children have them compared to adults. If you recall, I said 80% of the adults have it. We don't know it is because there's no studies. But it's the same for the sleep disordered breathing. The restless legs in kids may give them more hyperactivity, so they end up being categorized as having ADHD multiple times. Is less likely to have excessive daytime sleepiness, and Epworth sleepiness scale is usually normal, which is different from sleep apnea patients. Lack of concentration, irritability, mood changes, restlessness, again, hard to say if this is because of sleep disordered breathing, behavioral disorder, or they have restless legs, or they're fidgeting all the time. But both RLS and PLMS appear to be common in children with conduct disorders who present with aggressive behaviors, and they look like ADHD. And this is a new entity that's being described. This is literally from ICSD-3-TR, restless sleep disorder. It's a recently proposed condition, ages 6 to 18, characterized by restless sleep, observed large body movements during sleep, and then you would need a video polysomnographic proof of that, of 5 or more of these large body movements per hour. A true urge to move the legs is absent, so that's differential with RLS. But there is improvement with iron supplementation that suggests some relationship with RLS, or at least RLS pathophysiology. And what is periodic limb movement disorder? So to kind of summarize, we talked about RLS, clinical diagnosis. PLMS, polysomnographic finding. If the person has PLMS on the PSG and clinical symptoms of RLS, then the diagnosis becomes RLS with PLMS on the PSG. Keep in mind that 20% don't need to have them, right? But what is PLMD? Because this is a different animal. So what are the diagnostic criteria? So PSG demonstrates PLMS. So some people with PLMS on the PSG who clinically don't report RLS symptoms. PLMS frequency is more than 5 per hour in children, more than 15 in adults. We already talked that that's the cutoff for importance. The PLMS causes clinically significant sleep disturbance or impairment in mental, physical, social, occupational, educational, behavioral, other important areas of functioning. And most importantly, criteria D, the PLMS and their symptoms are not better explained by another current sleep disorder, medical or mental disorder. So long story short, PLMS associated with OSA should not be scored. PLMD cannot be diagnosed if the person has RLS, narcolepsy, untreated sleep apnea, or RBD. So if you have a person who doesn't have any of these diseases, has a sleep study, has periodic movements of sleep and daytime impairment, then that disease becomes PLMD. Which is why this is a disease that we hardly diagnose, at least in my experience, because most of the times people have comorbidities. So I would say PLMD becomes sort of a diagnosis of exclusion, but it's important to know clearly, who's who. So long story short, sleep apnea with leg movements, sleep apnea is the diagnosis, restless legs clinically with leg movements on the PSG, restless legs is a diagnosis. If somebody has narcolepsy or RBD, then they have PLMS in the setting of narcolepsy or RBD. Does it make sense? And I know this is complicated. It was for me when I was you, and we will continue to talk about this in the following 12 months. So differential diagnosis. For the adult population, I would say any type of disease that affects the vasculature, like arteries, veins, lymphatic drainage, and any type of disease that affects the nerves can be considered in differential diagnosis. So any type of neuropathy, leg cramps, lymphatic disease, positional discomfort, I would say that's a big one. Myalgia, like leg edema, radiculopathy, akathisia, habitual foot tapping, that's a frequent one. Any sort of venous insufficiency or PAD even skin conditions like eczema, any orthopedic condition, painful legs and moving toes. I really like how this sounds. And anxiety can also, give you something mimicking RLS. For the pediatric population, things look a little bit different. Growing pains, I would say that's the most important one. Motor tics, ADHD, which again, it's a big bucket of symptoms there. Muscle pain, leg cramps, Osgood Shatter disease, chondromalacia patella, arthralgias, sleep disorder breathing, PLMD, and akathisia, I would say less frequent, but growing pains, motor tics, that's probably the most frequent one. I know we jumped the guns with polysomnography as objective findings. Now to continue these objective tests, so what tests can be useful to assess for secondary causes of RLS? Iron studies always, iron, ferritin, TIBC, plus minus CBC. CBC is actually not really recommended unless you're looking really for anemia. Kidney function, because we said that's the second most frequent. Obviously, electrolytes count as well. For example, some people may report benefit with magnesium supplement. We don't really recommend. It's not in the guidelines, but it's no problem prescribing it if it makes them feel better. Blood glucose, A1C, why? Because there's this big relationship with neuropathy. Pregnancy test, we know why. B12, folic acid, I don't routinely recommend this unless I have a reason. Albumin, just because it gives you a state of overall nutritional status of the body, and TSH because why not, right? And treatment options. So here we start the new part of the lecture. So always start with lifestyle changes like with any other disease. So avoid or decrease the use of any potential triggering factors, alcohol, tobacco, caffeine use, keep a good sleep hygiene, moderate exercise, that's really important, aerobic, like stretching, always recommended, or light massage, warm bath. And there are few devices, heating pad, ice pack, pneumatic pressure therapy, like a foot wrap. Some of them are FDA approved, like this one, Restificores. I'm not advertising for anything, but it's available. They said it works. I have no patient using this. And what are the new clinical practice guidelines? So these are the ones that are to be published in this fall. This is the team that's working on it. That's all that's available on the ASM website. Please become members as fellows. You guys have no fee and you have access to everything.
Well, they charge us now, it's $50.
They do.
Yeah.
They do.
I
It
saw
used to
it
be
before
free.
that. But anyway, here's what they're looking. Adult patients with idiopathic primary RLS, with secondary RLS, refractory RLS, PLMD, and then pediatric patients with idiopathic and secondary RLS. And then they're looking at pharmacological management, surgical management, and non-pharmacological management. And then they're also looking at outcomes. I think this is very important, disease severity, including the augmentation rate, quality of life, and quality of sleep, wake after sleep onset, excessive daytime sleepiness, and then functional impairment, school, work, mood disturbance. That's really, really important. ADHD symptoms, side effects or withdrawal from meds, fatigue, and schoolwork performance and attendance. So first line therapies now for restless legs are iron, oral or IV, and alpha to delta ligands. So gabapentin, and nacarbil, which is the only FDA approved gabapentin for RLS, but it's very expensive. It's called Horizon, or pregabalin. Second line therapies, dopaminergic medications that used to be first line treatment are now second line therapy because of augmentation, and we'll talk about it in depth. It's estimated that 5 to 10% of individuals taking dopaminergic medication experience new onset augmentation each year. So I feel that the general consensus is that eventually everybody will. More or less. But again, I may be over talking about this. I guess we'll see more data once they publish it. And what are those medications? Ropinirole, pramipexole, roticotine patch. These are the ones that we still have many patients on them. And then what's coming a lot now is the opioids, and they can be considered, I would say, not necessarily as first-line treatment, but at least as an addition for refractory RLS. And they are more or less becoming the goal for severe augmented patients, especially if the addition of gabapentinoids is not controlling the symptoms. So 2024 ASM guidelines recommend a regular assessment of serum ferritin and iron plus TABC, a transfer in saturation. You have to get the patients in the lab in the morning, and they have to be fasting. That's very important. And because iron drops by 50% at night, and then also hold iron containing supplements for at least 24 hours, and ideally don't send them after they ate meat. Why? Because it has iron. So that's very, very important. At least for us who see pediatric patients, it's hard to achieve because you have them in the office and just send them to get it done. Luckily, we have the ferritin that's not circadianly, the level is not affected by the circadian rhythm. But this is, I would say, very important. I have, after coming back from the sleep meet, I started to send my patients next day in the morning to the lab. I'm hoping all of them, most of them can do it, but that's very important. So what are the goals? Ferritin 100, above 100, transfer in saturation above 20%. That's different from the previous guidelines. Keep in mind that ferritin could be an acute phase reactant. So obviously, all clinical judgment is important, and it's non-circadian, so that's good. But the transfer in saturation is circadian, obtained at earliest lab opening. That's what they said, may reflect recent ingestion of iron. So ideally, if they would avoid like a really big meal that has meat the day before the lab draw, that would be nice. And then again, 2024 guidelines for iron supplementation. We can do that orally or IV. For the oral iron therapy, they recommend to be administered on alternating nights. I feel most of my patients are on daily or even BID. On empty stomach with a vitamin C supplement, or that could be a vitamin C pill, or it could be orange juice. And what we usually recommend for a sulfate, 325 milligrams total, has 65 milligrams of elemental iron. You could also consider ferrous bicyclinate, 56 milligrams of elemental iron for people who cannot tolerate the other one. The iron infusion, the one that will have a strong 4 recommendation is the ferric carboxymaltose, 750 milligrams times 2 doses. I think this is similar to the previous guideline, if I remember correctly. What other iron IV formulations we could recommend? Low molecular iron dextran, ferromoxitol, monoferric derissomaltose. I have a hard time pronouncing this, but do not use iron sucrose or gluconate. So these are no. With this coming, this would be conditional for, this will be strong for.
Is that because it doesn't cross well?
Yeah, it's the absorption is not the best.
Do you have patients in whom you have to send for IV iron?
I personally have one that I think I just sent. I'm pretty sure many of my colleagues have more patients, but now the availability of IV iron depends on the institution. For us, we need to I send them to hematology because they have, they need to be monitored and so on. We'll talk about side effects, but I can do this in my clinic. Other institutions have the possibility to have the IV iron in sleep. Schedule the patient with them. we send them to hematology.
But do you think a significant amount of patients they respond well to the oral iron?
Yes and no, it depends on their other comorbidities. If you feel, and we'll talk about it in a second, if there's no improvement with oral iron, then the next step is to send them to IV.
Mhm.
If you have a child, which I've had, who but under any circumstance will take the oral iron, they'll go for IV.
Mhm.
So, plus, if you need a fast response, the patient has severe symptoms, you want a fast response. How do you get that? By IV formulation. So the IV, to kind of answer your question, I feel that we should look more frequently at IV iron. And we should prescribe it more frequently than we are. Because with the oral, again, you may have some other comorbidity with poor absorption. Say, for example, post-bariatric surgery patients, it's a given, it's never gonna go up, so they need IV, they may end up needing IV. Or if they have any other malabsorptive disorder, then yeah, why struggle? Or they cannot just tolerate it, like GI side effects. But how do you monitor the response? So you have to repeat iron levels at 6 to 8 weeks. That's what they said at the sleep meet a month ago. We usually do it every 3 months. If low with oral, move to IV. And that's the same like with the previous guideline. If low after IV, repeat IV. Obtain levels every 3 months then until stable, and consider reduction or discontinuation of iron supplement if ferritin less than 100. If you reach that point, then you will just monitor clinically the patient and they will self-monitor their symptoms. And then if their symptoms recur, then you will start over, recheck the blood iron the workup. If it's low again, restart the process.
So to answer your question, some places like Grand Rapids actually had a subspecialty called blood management. And we would send all our patients through there to get iron.
Oh, so it's like under hemonc or something?
It's not,
No, it's separate.
it's completely separate.
Completely separate.
Yes, it's like it's not like you're gonna take a board, but it is a completely separate technically field. A lot of critical care folks will also do that side. Yeah, so it's a good moneymaker.
Exactly. So for example, bigger institutions who have a restless legs clinic as as part of the Department of Sleep or Neurology, they may end up doing that there because that's all they do. They see restless legs patients.
Do you find in terms of insurance approval, because that was something that we had a lot of issues
Yes.
with, like the carboxymaltose?
600. Yes, because why? Here's why. They move this ferritin level to 100. That's way above normal.
It is.
Somebody comes with 40, that's normal. Insurance will say, why do you give IV iron? But then these guidelines are not published yet. And guess what? They will publish them in the fall. And then it's gonna take few years to insurances to acknowledge that and agree with it. By that time, we'll have new guidelines.
So
Yes.
when you send them to hemonc because they are managing, so you just tell them, this is the reason I'm sending. And they're okay with
Yes, because I have no nurse, I have nobody who does this for me in the clinic, like they need to be monitored.
You need like infusion.
You need infusion clinic,
Yeah.
exactly. So which it's a separate thing.
Usually hemonc, they'll have their outpatient
Correct.
clinic like really.
And once they get there, it's the second step, it's gonna be, is it covered or not? And if it's not, do the patient or their family wanna pay?
And so then after the infusions, then they come back to you for, repeat testing. And if everything is fine, we don't do anything. Just wait for
It depends
symptoms.
on their symptoms. We're not treating the numbers. We're
Yeah,
treating the
the
patient.
symptoms should also resolve.
What if they don't? So actually, in people with severe restless legs, they even go to a ferritin of 300, by the way. So 150, 300. So this is not the end. So, and it's evidence-based medicine that pushing the IV iron will help. And why is that? Because remember what I told you in the beginning, there's no correlation between this and this. So if this is 150, you still don't know how much it is.
And there's no metric, like biometric, that we can use to adequately predict like what
Correct.
crosses the blood.
Exactly.
barrier. There's no way to
And
do
you
that.
can check it in the
Yeah.
CSF and you can once do that.
So you often will see like severe patients, they come in, their ferritin's 200, still look bad.
Exactly. And they may still respond to the IV error for that reason. And then we are in a situation in which they have to pay.
Yeah.
For the infusion. Yes.
So the previous guideline, it was like, I think more than 50 was the.
Yeah, it was
50
50
was the cutoff.
And it
yeah.
just jumped like.
and
100.
75. Yes, and now it's a
So what are like,
Catching,
exactly.
because it doesn't have to be so low.
So I literally have to go back on all of my patients who are following up, and to whom I said, "Oh, your ferritin was 73. That's fine." I'm gonna go back, "Oh, let me give you some iron." See how that works. Obviously, or yeah. So that's another. And like why did they push on every other day? Is that because of the receptors? They will stop responding. And I have to be honest, I still have patients on BID or daily. I just have to change my smart phrase about it. But yeah,
Compliance is.
that too. And but you know what? Here's the thing. I feel that I myself would be more likely to forget if it's every other day.
Really?
Because I'm like, did I took it yesterday or not? So I don't know, but I guess that's just me.
Yeah. I would
Yeah.
say that, you know,
Yeah.
hold on, okay, do two things, you take your iron pill, you take milk of magnesia, which you just mentioned magnesium has something to do with it, and it works beautifully.
Yeah.
If I prescribe like some sort of Accusate or anything else.
Oh,
it
that's
doesn't
doesn't work. That doesn't
That
work.
makes sense.
Yeah.
That's good.
Yeah, so constipation, upset stomach, and the rest. And IV allergic reactions, although with the new formulation, those are really rare, like before, but anaphylaxis, right? So that's why you want them monitored. I can just give you IV while you're sitting in the next door and I'm seeing another patient here. So, and you guys know this. So, moving forward, now that we did not exhaust the iron topic, but at least we went over it. Alpha 2 delta ligands, so they inhibit the calcium channels and they decrease the level of glutamate and are all strongly recommended for treatment in a 2024 ASM guideline. So you can easily start with it. Let's say somebody comes, their ferritin is 102, and then go ahead, start with the gabapentin. And unfortunately, the top of the, I can't see this, but anyway, so what are the three medications? Gabapentin, pregabalin, and gabapentin and narcarbil. This is the only FDA approved for RLS. It has a better bioavailability, a relatively stable plasma levels, and then elimination half-life of 6 hours, and it lasts for 18 to 24 hours, which makes it different from these other two guys. The gabapentin and narcarbil, you should take it with food for better absorption. The problem with gabapentin is that it's very poorly absorbed, like 50%. So that's a big issue. The pregabalin, it works better on an empty stomach, FYI. And then time to maximum blood level, you see some differences here. Elimination half-life, gabapentin, pregabalin, they're renally excreted, so we always have to look at the kidney function, especially for elderly patients, and especially if they're already taking other medications that are nephrotoxic, like blood pressure medicine, like ACE inhibitors. The gabapentin and narcarbil has an intestinal metabolism, but also renal excretion. I have to be honest with you, I personally have no experience with this because it's so
Okay,
expensive.
I was gonna ask, like, how good is insurance approval for that? I feel like gabapentin's so cheap.
Yeah, here's your answer. So I'm pretty sure Dr. Oakley can tell you more about this. I personally have no patient on this. I feel that with these new guidelines, there's gonna be a bit of a change in our practice. So initial dose, 300 milligrams with dinner or in the evening. For pregabalin, 75, 1 hour before symptom onset. For the narcarbil formulation, 600 milligrams with dinner. Maximum daily dose, 600 milligrams in 2 doses. Anything above that, they said a month ago that it's not going to bring more benefit. For the pregabalin, 300, you may be going to 450. There was a question mark when they had this presentation. For the enacrobil, 2400 milligrams, they want to add 600 milligrams per week to a maximum dose of 2400. The same for pregabalin, increase weekly, kind of the same for gabapentin. Most of the time we start with 300 and then we may double to 600 and see what's going on. So side effects, dizziness, ataxia, somnolence, respiratory depression, that's important. Even increased risk for severe exacerbation of COPD, that's important. Weight gain with pregabalin, some leg edema, and depression and suicidal ideation, that's important. Specifically, we'll see in just a second in patients who suffer with augmentation secondary to dopamine agonists because they become suicidal because of how severe their symptoms are. And on top of that, we want to transition them to this or opioids who have more of this.
Sure.
So it becomes very complicated. And those patients need really, they need a really close follow-up, even like weekly phone calls from the provider. And speaking of the little devil, the dopamine agonists, so they used to be first-line treatment. We still have probably most of our patients on these medications. A little bit of comparison. So pramipexole, ropinirole, rotigotine patch. Time to maximum blood level pretty fast. This one is a patch, right? So stable plasma levels for 24 hours. Elimination, half-life, same rotigotine patch seems to be favored. The problem is that this is the one that it's harder to get them off. Why are you going to cut the patch? So it's harder for the augmented patients to get them off of this. The pramipexole, renally excreted, ropinirole has a hepatic metabolism, but renal excretion. Same with rotigotine patch. Initial daily dose 0.1 to 5 for pramipexole, 0.25 to 0.5 for ropinirole, 1 milligram for rotigotine patch, maximum dose 0.5, 2 to 4 milligrams, 3 milligrams, anything above 4. And unfortunately that happens. So I have a patient that PCP prescribed 2 milligrams TID of ropinirole. When you have to, with this patient, you have to follow the symptoms. When do they happen? Like, why would you give it in the morning unless they are augmented and then or they have like tolerance and then their symptoms start being over 24 hours. So yeah, you need to follow the disease, right? When do you get symptoms and what is affected, lower, also upper, and kind of to follow with the medication. Ideally, you want to give these medications, any restless medications before the symptoms have started, not after, and then you're trying to control them, right? So augmentation, what is it? It's a result of chronic use of dopamine drugs that leads to a decrease in the brain's natural dopamine levels. Decreased presynaptic dopamine synthesis that leads to a decreased dopamine release and uptake at the synapses level that leads to a decreased function of postsynaptic dopamine receptors that leads to a decreased dopamine signal and subsequently increased RLS symptoms and decrease in dependency on the dopamine drug. So if you remember on one of the first slides, we have a hyperdopaminergic presynaptic state. Now it becomes a hypodopaminergic presynaptic state and a hypodopaminergic postsynaptic state. And you want more and more, more and more, and you get those MyChart messages from patients. Oh, this is not working. Can you increase the dose? And that's what you do. Increase the dose. Well, no.
But that does happen.
So yeah, obviously it's going to be a big change in practice for all of us. So it's basically an iatrogenic exacerbation of RLS symptoms. We are doing this. And you will have earlier occurrence of symptoms in the afternoon or even earlier in the day than before treatment initiation. So suddenly they have worse RLS than they ever had. the spread of symptoms to the upper limbs, and reduced latency until symptoms manifest during periods of rest. And the patients have a paradoxical worsening upon increasing the dose. So the more you increase, the worse it's getting. Is especially common in patients that are taking levodopa treatment, and was initially found in 70% of these patients, so almost three-thirds of patients. The RLS patients may exhibit impaired postsynaptic response to decreased dopamine stimulation after long-term administration of low-dose dopamine agents, possibly due to dopamine receptor desensitization and interaction of dopamine receptors. So long story short, the mechanism is at the level of the receptor. And the severity, kind of how it progresses in these patients. First of all, loss of efficacy. The patients don't have an early onset, but they need a dose increase. And then it becomes mild augmentation, 2 to 4 hours advance in their symptoms, then moderate 4 to 8 hours symptoms onset advance. So the symptoms happen earlier and earlier and earlier in the day. And this dose increase needed, this is actually called tolerance. It's actually 2 side effects. It's tolerance and augmentation for the dopamine agonists. And then it progresses up until it becomes severe. Symptoms are present for 16 to 24 hours per day.
Might be stupid. I struggle with, how do you tell the difference between augmentation versus natural progression of RLS?
That's a great question. And I would say my answer is get them off the dopamine agonist and then see.
That's the only way to,
Yeah.
Okay.
Because this is a big confounding factor. Like literally right before the sleep meet, I had a patient who messaged me. It was literally the week before I left. And I was like, oh, okay, it's the dose. Your opinion. Hit enter. And then I go to the sleep, I'm like, what did I do? And I'm like, no, next time I'm checking all the iron again and again and again. I mean, I'll go to the patient's house in the morning if I have to throw that blood iron. And like, right, because I guess obviously we know that iron helps, but we're also science people, right? We need objective data. And also we have insurance. Yeah, right. So treatment plan. This is again my own compilation from slides from the sleep meet. I'm sorry I didn't have time to put here. I'll have to work on these slides again. But what's the treatment plan? And it has to be done in this order. So they said the following: correct underlying exacerbating factors if present and if possible. Always go to iron deficiency, go back, recheck iron, and always consider IV iron supplementation. Like don't wait for the oral iron to start working, start being absorbed and start working. Just give them IV. Correct sleep apnea if there is, or assess for it, and precipitating medications, which we're going back to that first slide that was very busy, but it has all those meds, all the Benadryls that the patients are taking, all the other antihistamines that they're taking, all the SSRIs that they say 20% of US population is on an SSRI. I don't agree with that. I think it's more than 50%.
It should be more.
SSRI or SNR. Sorry, I think personally, we like that. So, but like it's PPIs, H2 blockers. Half of my patients are on omeprazole. So yeah, so it's precipitating medications. I think that's a big one. Even that, yeah, put it there. So first, always add and maximize a gabapentinoid, alpha to delta ligands to tolerable dose, and try all of them. So before you stop decreasing the dopamine agonist, you first have to control their symptoms because these patients are literally going crazy. Second, start dopamine medication taper as much as possible, ideally slowly, but some providers are actually doing it cold turkey over 2 weeks. But ideally between at least 2 and maybe 3+ weeks, even months, even over 12 months if you have to. That's what Dr. Winkelman says. Then add a low dose opioid like methadone or buprenorphine to alpha to delta ligands if a dopamine agent is unable to be tapered off completely. But you may not need that. Continue dopamine taper to discontinuation, if possible and ideally. And then taper the alpha to delta ligand as possible if the opioid is present. Why? Because your goal is not to give them 2 medications that suppress breathing. They like give them just one. And if the disease could be controlled just with a low dose opioid like the methadone or buprenorphine and as a monotherapy, then why not?
Okay.
Right? And always consider IV iron supplementation in any of these steps. Because why? The IV iron would definitely work faster than oral and will help you to get them off the dopamine agonist. So what else is important? In the process of dopamine agonist tapering, the RLS symptoms may worsen dramatically. We are dealing with dopamine agonist withdrawal syndrome, right? And the experience can be very, very difficult for the patients. Specifically, these effects on mood, some patients literally become suicidal. They're sleep deprived, they have mental clouding, they have difficulty walking because all that dopamine is no longer in their synapse. So some patients may require to resume the dopamine agonist, but at a lower dose. Again, just as a bridging, but this, we're talking about really severe cases that end up in these RLS specialized clinics.
So you end
right?
up just, you need to get them off of that eventually.
Because it's more important what? For the patient to maintain their sanity and to be able to function. Do not forget potential psychiatric effects of opiates and gabapentinoids. So these adds that increased risk for depression, anxiety, and suicidality adds to dopamine agonist withdrawals. So this is when it becomes very sensitive and close follow-up with the provider is important. And they said they have patients like weekly phone calls, my chart messaging, as I mean, obviously my chart messaging is becoming big problem for our time, and availability, but I guess these are people that really require our attention. Because why?
What's a typical like tapering rate for the dopamine agonists?
I have that.
You have that? Okay.
I just, it
It's
was
not on
too
there,
much
okay.
for this. I think what we should do, I will go over again these slides and I'll make a second presentation. Because, you know, when you are on metro rotation, we have the primary reader does the teaching with the two, and then we repeat basically with the other two. I think, oh, you guys are here.
Yeah,
Okay.
those two.
Yeah. So, and then we'll go over these things. Because I have all that I got from the slides of the people who presented, and maybe by fall we'll also have the real guidelines, but that's literally based on their own experience.
Okay, so it's
Like,
not standardized.
but these are people who do this
all the time.
like I'm somebody who never did this, right? I'm just
Okay.
presenting it. But yeah, I mean, this is important, and it's I guess why is it so important? Because we did it. It's iatrogenic. We did it, right? We
Yes.
kept on increasing the
Mhm.
doses, and what it was first line therapy for the guidelines, right? So when should we consider opioids for restless legs? If we have an inadequate response or intolerance to first line approaches, the iron, any formulation, and the gabapentinoids. If the patient has augmentation secondary to dopamine agonist use, right? We just talked about that. If we have refractory RLS, we can even consider opioid monotherapy. That ideally would be the goal, or combination, but always go back to the good old iron. And if the RLS does not improve with correction of exacerbating factors. And it's actually very low doses that they recommend. For example, for methadone and buprenorphine, who have the prolonged half-life, That's why I highlight this in blue. It's a 2.5 to 5 milligrams. The highest dose is 20. The dose for chronic pain is 50 to 150. So it's very low dose. For the buprenorphine, like the sublingual film is like even 1/8, 1/4 of a film, like a very low. The patient really cut.
Yeah, they just.
So 0.5 to 1 milligram, the highest dose 6 milligrams. And we could also use tramadol, codeine, morphine, oxycodone, hydrocodone, based on, you know, the symptoms, how severe they are, how frequent, what part of the day they happen. But the two drugs that they emphasize most are these two. Yeah, but these ones are not. Yeah, which is why they wanted this. That's what.
Pretty much like being.
And then so the way they prescribe this, and that's a very, very good point. It's because, right, they are not approved for RLS. So if you write methadone and you associate your order with RLS, it's not going to get paid. So they prescribe this for chronic pain secondary to RLS. So that's how they get it approved, because that's how it's FDA approved, right? And insurance will recognize that, will ring the bell. Number one thing. Number two thing, obviously that opens a whole new door of controlled substances, right? Because we've been working in the past, 5-10 years to go away from prescribing opioids after years of prescribing opioids. And now what? Come the ASM guideline of RLS, that's a very frequent disease, and says, oh no, you know what? Start prescribing opioids again. So this created a really big boom in the rooms with these presentations. So as you guys know, we have the tools, right? Always check ORs. Always. Like there is an opioid risk tool. I have it. I just, for the sake of time, I didn't put it in these slides, but I will make another presentation on that. Yeah, I mean, look at your patient. Any history of high risk, right? I mean, you would just not prescribe it to them. Right. So that comes, you know, clinical judgment, and use the objective tools that we have in hand. But my understanding is, and I repeat myself, I personally have no experience with opioids in RLS. I don't think I have that severe patients with RLS, or not yet. But my understanding is from these providers who are dealing with this on a daily basis, and all they do morning to evening, is that there is a fantastic response to very low dose of methadone and buprenorphine, and most patients end up being on monotherapy, and they are very happy. And last but not least, so what is the opioid choice based on daily duration of bothersome RLS symptoms? So if they have symptoms about 4 hours a day, then consider oxycodone, tramadol, hydrocodone. 6 to 10 hours oxycodone extended release, more than 10 hours a day, the methadone and the buprenorphine. That's what Dr. Winkelman says. He's the one most experienced in that regards. Side effects, right? Outside of controlled substance agreement, UTOX, in-person visits, at least every 3 to 6 months. So we're going, right? We're not pain management doctors, but we need to comply to the state laws. And this institution does require the controlled substance agreement, the UTOX, the everything, same like university hospitals. So constipation, sleepiness, itching, nausea, you guys know all of this. Sweating, I said check testosterone in men. Central sleep apnea, if you have any concern about this, do PSG, but Dr. Winkelman swears that these low doses do not bring up on the table significantly increased rates of central sleep apnea. Why? Because, you know, I guess we create a new dragon here, right?
Sure.
More, okay, we're treating their RLS, but now everybody is going to need a bicep SD to control the central sleep apnea that's drug induced. And always keep in mind QTC prolongation with methadone. I guess this was an IM board question for me. So, and any questions? And again, I'm pretty sure there's many, it's all new to me. I would say 70% that it is for you guys too. But I guess we'll see more and more in these. Once they publish the guideline and more people start using it, I guess we'll have more data. So this is actually from the old guidelines. I'm waiting to see what they're gonna say with the new ones. I don't expect much change, but management of RLS during pregnancy, as Jasmine already mentioned, iron, right? You don't really want to go on any of the other medications because they are teratogenic, right? Try to stay away from those. With the kids, the same iron. With kids is, I would say, a bit obvious because they are either drink a lot of milk, so they end up having iron deficiency, or they're picky eaters, so they don't eat their iron. So it's a little bit more obvious. But first line therapy should, outside of iron, also gabapentin, and we have liquid formulation, and I guess we've been using it a lot, including off-label, so we can try it. And then the ferritin level, I'm assuming it's gonna be the same. There was literally nothing in their presentations about pediatric patients, but just by extrapolation, I'm assuming we're gonna move to the same, because why not?
Yeah.
And then you could consider other drugs, including the clonidine, but again, off-label.
Works pretty well though with my patients because they're usually taking it for the reason.
Of course, also for insomnia, right? So what is the prognosis of patients with RLS? It's similar for pediatric and adult patients. It's a lifelong condition. There is no cure, but there are therapies, right, that can control the disorder, minimize symptoms, and increase periods of restful sleep. It's not uncommon in RLS patients to have, let's say, symptoms earlier in life, and then there's a period in their life when the symptoms disappear, and then there's a recurrence of symptoms after, I don't know, 5 or 10 years. I actually just saw a patient yesterday who came to me for sleep onset insomnia. She was using the beautiful Benadryl, like 99% of the patient, or any of the PM formulation with Benadryl. And she's coming, and when I'm asking her about restless legs, because, we do the screening, we ask all the patients for the first visit, of course, oh yeah, I used to have that years ago, but then I was fine. And now suddenly they're getting so bad, especially with this leg. And I'm like, okay, what are you taking? Benadryl, like couple of, like she was taking as an SSRI for mood, something else, which doesn't sound okay. And she's like, oh, I can't fall asleep at all, and now I'm taking Benadryl every evening. So, and it's very hard to get them off Benadryl. They love it.
They love Benadryl.
They love it, right? They love it. And even if I tell them it's not safe for your QTC, it's not safe for the anything, you can take it as needed. I was taking it as needed during night float for 2 weeks to sleep, right? But they look at me like, but it's working. Like, why are you telling me it's not in the guidelines and it's not a sleep aid?
Yeah.
Same thing with the melatonin, which I think it's coming. They're working, making it. Yeah. Good. So lifestyle, emotional, relationship impact of RLS. My previous presentation had the Odyssey 1. Now we have the Odyssey 2, which was published in 2020. It's a big survey, more than 3,000 patients. It has had a sponsor, and it's been done by RLS Foundation. And like, what are some key findings in relationship to patients and their spouses or partners? RLS is more common and severe than many other chronic health conditions. This is going to my first slide. Depression, suicidal thoughts, major consequences, specifically because it's so undiagnosed, because why we don't ask about it. People with RLS experience excessive delay in diagnosis and treatment. So most of people reported the time frame between sleep onset and diagnosis of about 8 years. And about 2 years since they started to say they have symptoms until they got the real diagnosis. And then RLS treatment options and medical care are inadequate. 2/3 of the patients said that their current medications work somewhat well or very well. And guess who had the highest success rates? alpha to delta ligands, and methadone. So, and of course, they said it did work in the beginning, but then it stopped working because why? First line treatment was dopamine agonist. So that's what we were prescribing. So for the spouses, RLS, it does affect their life, the life of the partners, like their sleep is impacted. Some people need to sleep in a different room, social events, travel, relationship, mood, happiness, and even like sex was affected in about 20%. And right, that's important. Sometimes, you know, in the same way patients arrive to our clinic saying, my wife is saying that I'm snoring. What brought you in today? I'm saying that I'm snoring. I guess RLS is also a reason why the partner says that something, they're wiggling and I can't sleep. Thank you. So that's all.